afternoon everyone. Today we are having a very important discussion regarding the different aspects of management of pulmonary embolism. So venous thromboembolism, that is encompassing pulmonary embolism and deep vein thrombosis, constitute one of the big three cardiovascular diseases, the other two being myocardial infarction and stroke. So VTE, as abbreviated it's known, encompasses PE and DVT, and estimates of the global incidence of VTE ranges from 1.2 to 2.7 cases per thousand per year. Pulmonary embolism elicits a complex cardiopulmonary response, which includes increased pulmonary vascular resistance due to vascular obstruction, release of different neurohormonal agents, and pulmonary artery baroreceptors. It leads to impaired gas exchange, which is caused by increased alveolar dead space. There is an impaired carbon monoxide transfer caused by loss of gas exchange surface, alveolar hyperventilation caused by reflex stimulation of irritant receptors, and increased airway resistance due to bronchoconstriction, and ultimately decreased pulmonary compliance due to flooding of the lung hemorrhage, and loss of surfactant. Pulmonary embolism, this is just a brief pathophysiologic basis of pulmonary embolism, which basically leads to increase in the PA pressure and increase in the RV afterload, which leads to RV dilatation and dysfunctioning, and ultimately it will decrease the LV preload and LV output, and this will lead to systemic hypoperfusion as well as decrease in the coronary perfusion, which will lead to the RV demand supply mismatch and generation of RV ischemia. So this is just a classification of acute pulmonary embolism. So the massive, submassive, and small to moderate PE. This is the basic categorical classification of acute pulmonary embolism. Majority of the cases are of small to moderate pulmonary embolism, while only 5 to 10% of cases are having massive pulmonary embolism, while 15% are almost having submassive PE with a very high risk. So what is massive PE? So whenever there is a hypotension with systemic blood pressure less than or equal to 90, or poor tissue perfusion, or there is a multisystemic organ failure with extensive thrombosis such as saddle thrombus in the bifurcation, or in the case of submassive there is hemodynamically stable but there is a moderate to severe RV dysfunction or enlargement coupled with a biomarker elevation, indication of a RV microinfarction and or RV pressure overload. Well, when there is hemodynamically stable with RV dysfunction or biomarker elevation but not both. In the case of small to moderate PE, patient is having normal hemodynamics as well as normal RV size and function. So regarding the current anticoagulation practice for acute PE, so pulmonary embolism manifests with a wide spectrum of acuity ranging from mild to severe. So the rapid and accurate risk stratification remains the cornerstone of the management. Low risk patient having an excellent prognosis, while high risk patient requires intensive hemodynamic and respiratory monitoring and support with pressures, mechanical ventilation, or ECMO support. In addition to anticoagulation, like advanced management options also include systemic thrombolysis, pharmacomechanical catheter assisted therapy, IVC filter placement, or surgical embolectomy. So acute PE, the risk patients of acute PE on the basis of clinical evaluation, anatomic extent of pulmonary embolism, right ventricular size and function, and cardiac markers are risk stratified either in low risk and high risk, and ultimately the management is thereby decided. So this is a pulmonary embolism severity index in simplified PESI, which is an important score to risk stratify the cases of pulmonary embolism. So broadly different 10 to 12 criteria are there in the PESI, which includes age, sex, history of cancer, heart failure, chronic lung disease, heart rate, systolic blood pressure, respiratory rate, temperature, and altered mental status and oxygen saturation. So the patient with a score of 0 are considered to be at low risk of PE, while those with a score of 1 or higher are considered at high risk. So regarding the parenteral anticoagulation, the role of unfractionated heparin. So unfractionated heparin is a highly sulfated glycosaminoglycan that is partially purified, most often from pig intestinal mucosa, and acts primarily by binding to antithrombin, which is a protein that inhibits the coagulation factors, chiefly of 2A, 10, 9, 11, and 12. Heparin subsequently promotes a conformational change in antithrombin, which accelerates its activity by manifold. So it does not directly dissolve the thrombus. So the dosage of unfractionated heparin should be started at 80 units per kg bolus, followed by continuous infusion of 18 units per kg per hour. and regular monitoring of APTT should be done, and it should be targeted between 1.5 to 2.5 times of the normal control value. Regarding the role of low molecular weight heparin, they are basically just the fragments of UFH that exhibit less binding to the plasma proteins and endothelial cells, and thereby having a greater and predictable bioavailability with a predictable dose response and a longer half-life compared with the unfractionated heparin. LMWH is recommended as a monotherapy without anticoagulation for cancer patients with VTE. Regarding the role of fondaparinux, it is an anticoagulant pentasaccharide that specifically inhibits the factor 10A. It can be like a thought of an ultra low molecular weight heparin. It is having a half-life of 17 hours, and elimination is prolonged in patients with renal impairment. So it is often used off-label for the management of suspected or proven heparin-induced thrombocytopenia because it does not cross-react with heparin-induced antibodies. Now, regarding the heparin-induced thrombocytopenia, HEAT is a very serious immune-mediated complication of heparin. It occurs approximately 10 times more often with unfractionated heparin than with LMWH, and basically because of the immunoglobulin G antibodies which bind to heparin platelet factor 4 complex and thereby releases the prothrombotic milieu, and this will promote excessive thrombin generation which results in paradoxical thrombosis despite thrombocytopenia. So it usually manifests at extensive and often bilateral DVT or pulmonary embolism, but presentations of other vascular diseases like MI, stroke or other unusual types of arterial thrombosis are also described. The different 4 components of HEAT are thrombocytopenia, the timing of decrease in the platelet count, thrombosis or other sequelae, and absence of any other explanation. Should be suspected when the platelet count decreases to less than 1 lakh or 50% of the baseline. It is usually mild in the range of 40 to 70,000, and typically it occurs after 5 to 10 days of heparin exposure and most often in surgical ICU settings. And LSI testing quantifies the antiplatelet factor 4 heparin antibody levels, which are measured in OD units, and higher the OD value, the more likely the diagnosis of HEAT with thrombosis and of acute PE. So the serotonin release assay is also the reference standard laboratory test for HEAT. So when HEAT is diagnosed, the unfractionated heparin or LMWH should be discontinued immediately, and patient should not receive any platelet transfusions, and parenteral direct thrombin inhibitor such as argatroban or bivalirudin should be used. Warfarin, it prevents the gamma carboxylation activation of coagulation factors 2, 7, 9 and 10, and the full anticoagulant effect of warfarin becomes evident after 5 to 7 days. Even if the prothrombin time which is used to monitor the warfarin effect becomes elevated more rapidly. So for the patients with VTE, the usual INR range is between 2 to 3, and when we are starting warfarin, like bridging is very important with heparin. So initiation of warfarin as monotherapy may paradoxically exacerbate the hypercoagulability because warfarin decreases the level of protein C and protein S. So overlapping and bridging of warfarin for at least 5 days with heparin counteracts the poor coagulant effect of unopposed warfarin. Different NOACs, that is they are having a very rapid onset of action and provide full anticoagulation within several hours of ingestion. They are prescribed in fixed dosages. They are having a very short half-life, and for VTE treatment many different randomized trials have shown that they are non-inferior to warfarin for efficacy and are superior for safety. And 4 of NOAC molecules are licensed for VTE treatment: dabigatran, which is an oral direct thrombin inhibitor, and other 3 factor 10A inhibitors, particularly rivaroxaban, apixaban and edoxaban. These are just the different summary of the different trials, particularly which have shown the efficacy and safety of NOAC for VTE, acute and extended therapy. We can see that there was a remedy and recover trial for dabigatran. Similarly, Einstein PE and Einstein DVT for rivaroxaban, Amplify for apixaban, and Hokusai VTE study for edoxaban. So there is a very high risk of recurrence of VT after the discontinuation of anticoagulation. So men suffer recurrent VT more often than women. So in a different patient level meta-analysis, the recurrence rate for those with unprovoked VTE after discontinuation were as follows: like it was 10% for men versus 5% for women at 1 year, 16 and 8% respectively at 2 years, 22 and 9% at 3 years, and 43 and 11% at 5 years for men and women respectively. Persistent thrombus imaged on the chest CT does not predict the recurrent PE. and approximately one half of patient will have persistent thrombus and chest CT even 6 months after the initial event. So that should not lead to further admission and detailed evaluation. So those patients with unprovoked VTE have a higher recurrence or rate of recurrence than those with a provoked VTE. An Einstein choice study investigated the optimal medical regimen for extended duration therapy in patients who have completed 6 to 12 months for index acute VTE event. And both patients were enrolled in this trial are randomized to 1 or 3 groups, rivaroxaban 20 versus rivaroxaban 10 versus aspirin 100 mg daily. Both doses of rivaroxaban were superior to aspirin in preventing recurrent VTE. And now the emerging role is also there for the extended duration aspirin for anticoagulation in VTE patients, and 2 pivotal studies have tested the hypothesis of low dose aspirin versus placebo in patients with unprovoked VTE who have completed 6 to 12 months of standard anticoagulation, and the results were impressive, which showed a 32% relative rate reduction in the rate of recurrence of VTE and 34% RR in the rate of major vascular events. Now talking about advanced therapy which are like systemic thrombolysis. So FDA has approved the usage of alteplase for massive PE in a dose of 100 mg, which is delivered through a peripheral vein as a continuous infusion over 2 hours, and patients who receive thrombolysis up to 14 days after the onset of symptom can derive benefit, probably because of its effect also on the bronchial collateral circulation. These are the different endovascular treatment options for pulmonary embolism. Like catheter directed thrombolysis with unifuse or Craig-McNamara catheter, thrombolysis and ultrasound which is ecosonic catheter, then pharmacomechanical thrombolysis with angiojet and power injection of fibrinolysis. Different mechanical thrombectomy, catheter mechanical thrombectomy includes like fragmentation with pigtail or balloon angioplasty, direct aspiration or Aspirex rotational thrombectomy system or rheolytic thrombectomy, and other newer emerging thrombectomy techniques like indigo, that is penumbra, and float river system, which we will also discussed later on in the coming slides. So regarding the catheter directed thrombolysis, the typical dose of tissue plasminogen activator in the pharmacomechanical catheter based procedure is 24 mg or less, compared with 100 mg in the case for systemic administration. And different interventional mechanical techniques performed in conjunction with this low dose thrombolysis include the mechanical fragmentation and aspiration using a standard pigtail catheter, clot pulverization with a rotating basket catheter, rheolytic thrombectomy, or pigtail rotational catheter embolectomy. Low intensity ultrasound facilitated fibrinolysis is also a novel approach, and ultrasound disintegrates the fibrin strands, increases the clot permeability, and disperses the infused fibrinolytic drug into the clot through the acoustic microstreaming effects. So you can see here, we can see that bilateral low power ultrasound facilitated catheter directed thrombolysis is done in the case of massive PE. So in the dual catheter, the outer catheter has also the side holes to permit the administration of fluids and medications such as alteplase, while the inner sheath contain catheters with ultrasound transducers, which you can see directly in both the right and left pulmonary arteries. So Craig-McNamara is another and unifuse catheters are also available for the CDT. These catheters are having multiple side holes or slits to facilitate the uniform distribution of fibrinolytic agent within the thrombus. So this is just a unifuse catheter with a occluding ball wire. So this catheter utilizes the radiopic markers on either side of undesired material for the ease of placement and visualization radiographically. And then after the insertion of the sheath, remove the guide wire and introduce the occluding ball wire through the unifuse catheter, and ultimately after the occluding ball wire, inject the thrombolytic into the catheter through the occluding ball wire. So this will lead to the uniform dispersion of thrombolytic agent with pressure across the clot, and that will increase the dissolution of the clot. So this occluded ball wire is inserted, and this provides the proper force to activate the pressure response outlet. So this is the mechanism by which the different catheters with multiple side hole works. Another is a fountain catheter, which is having also multiple side holes arranged radially across the length, and that will also increase the perfusion of fibrinolytic agent uniformly throughout the clot. This is the again a system or a pictographic description of fountain infusion system. The ultrasound assisted catheter directed thrombolysis, so that to improve the efficacy and safety of clot clearance, the fibrinolysis can be combined with ultrasound waves using a multi-hole catheter. To be precise, ecosonic catheter is available, which is of a multi-hole infusion catheter with an ultrasonic core and a control unit. So here we can see in the image the infusion catheter with inside the ultrasonic core is visible, which helps in dissolution of clot. Another emerging system is a rheolytic thrombectomy, angiojet. The mechanism of this angiojet is a high pressure saline jet in conjunction with aspiration. So this creates a venturi effect. So what happens that saline jet travel backwards at high speed to create a negative pressure and creating a powerful vacuum or venturi effect, and the cross stream window optimizes the fluid flow for more effective thrombus removal, and thrombus is drawn into the catheter where it is fragmented by the jets and evacuated from the body. So it is a double lumen system with diameters ranging from 4 French to 8 French, and different trials and studies have been neutral as far as angiojet has been considered. Float river aspiration system. This is another newer device made by Inari Medical. It is a mechanical thrombectomy device specifically designed to extract the thrombus from the larger vessels such as the pulmonary arteries. It is available in the three sizes 16, 20 and 24 French guide system with large bowl syringe for aspiration thrombectomy. As well, it is also having an optional self-expanding nitinol discs distally to disrupt the thrombus. So the 16 French catheter can be used through a 20 or 24 French catheters to reach more distal branches. So this is just a pictographic description of how the float river aspiration works, and just it is basically works by retrieval and aspiration system, and ultimately the nitinol discs are deployed, which leads to the complete removal of thrombus from the lumen. Another newer is the Indigo, that is a penumbra mechanical thrombectomy device for pulmonary vessels. It consists of 8 French aspiration catheter connected to aspiration pump and containing a metal wire with an olive shaped distal tip that both maintains aspiration catheter permeability by facilitating the aspiration and fragments of the thrombus. So in this case, straight and curved both catheters are available. So the enlarged image of the this Indigo aspiration catheter and the Indigo aspiration pump, which is producing a sustained negative aspiration power of 28 millimeter of mercury. So this is a pictographic description of an extract PE trial, which is the largest study for the penumbra thrombectomy system till date, and it leads to impressive 30% relative risk reduction in RV by LV ratio pre versus post procedure. And there was also 1.7% relative risk reduction in major adverse event within 48 hours, and 98.3 were the patient who did not receive any intra-procedural thrombolytics. So this is just a penumbra thrombectomy system. So we can see that Indigo aspiration catheter is assessed to the pulmonary vasculature to reach the site of the thrombus or embolism, and this is A is showing the pre-treatment image, B where the treatment and the aspiration is working, and C is the post-treatment of pulmonary embolism with Indigo aspiration and successful clearance of thrombus from the pulmonary vasculature. Last option is a surgical embolectomy, of course. An emergency surgical embolectomy has re-emerged for the management of patients with massive PE and systemic arterial hypotension or submassive PE with severe RV dysfunction, in whom contraindications are there for thrombolysis. It is also suitable for those patients with acute PE who require surgical excision of a right atrial thrombus or a closure of a patent foramen ovale. It is often used as a rescue therapy for patients in whom the thrombolysis is not successful. So results are best when the patient undergoes surgery before they become pressure dependent or before the onset of shock and multisystemic organ failure. These are the different images of the clots which have been removed surgically from the pulmonary vasculature of a patient presenting with massive pulmonary embolism. Regarding the usage of IVC filter, the generally accepted consensus recommendation for the filter includes major bleeding even with full dose anticoagulation, when there is major contraindication to full dose anticoagulation, or when there is a recurrent PE despite well documented full dose anticoagulation. And a special population in whom the IVC filter may benefit, like patient with a massive PE or high risk submassive PE, or patient undergoing surgical pulmonary embolectomy, or surgical patients during preoperative evaluation who are at high risk of VT with a concomitant high risk of bleeding if anticoagulated. So pulmonary embolism is, as we all know, it's a very common preventable cause. So the angel catheter is also a newer device which is designed with a limitation of current standard of care, and it can be placed at the patient's bedside, and its permanent attachment to the central line catheter also ensures the filter is removed in every situation. So this is the angel catheter, which is having a unique design, having filter also connected with a central vein catheter. So in this case, the pressure monitoring as well as the different therapies can also be administered simultaneously with the usage of IVC filter in acute intensive settings. Regarding the chronic thromboembolism, pulmonary hypertension occur in almost 2 to 4% of patients, and usually the CT angiography reveals or the diagnosis of choice, and primary therapy for it is surgical pulmonary thromboendarterectomy, which is having excellent outcomes. So these are the common regimens for the venous thromboembolism prevention in a hospitalization setting, and those patients undergoing general surgery as well as those patients undergoing major orthopedic surgery. This is a Padua prediction score for identification of hospitalized patient at a risk of venous thromboembolism. So you can see here the different risk factors like cancer, previous history of VTE, immobility, thrombophilia, trauma, surgery, age, heart, respiratory failure, acute MI, stroke, infection, obesity and hormonal treatment are included. There is high risk of developing PE when the score is more than or equal to 4. Mechanical prophylaxis consists of intermittent pneumatic compression devices with like a graduated compression stockings, and pharmacological is more effective than mechanical prophylaxis, and mechanical measures are reserved primarily when there is a contraindication to anticoagulation. Advances in venous thromboembolism prophylaxis in major orthopedic surgery. So extended prophylaxis after hospital discharge also decreases the risk of VTE, and so in this case there is an evidence to support the use of virtually any prophylactic measure in patients undergoing major orthopedic surgery, and approved approaches include the usage of LMWH, warfarin, Novak, aspirin and mechanical measures. And lastly but not the least, emotional support is very much important for pulmonary embolism patients, because this disease is very emotionally draining. So they and their families seek reassurance that most of the patients have good outcomes, and they must confront like the different PE related issues such as genetic predisposition, potential long-term disability, changes in the lifestyle related to the medication usage, and the possibility of suffering a recurrent event. So clinicians can help allay this emotional burden by discussing the implications of pulmonary embolism with patients as well as their families. Thank you.